Hi, welcome back. Let's start our presentation. Today, my topic is morphology and management of C-shaped canal system in mandibular premolars. A C-shaped canal presents a continuous isthmus connecting some or all canals and forming a shape of the letter C in a cross-sectional configuration. The top row of pictures shows path flow of the C-shaped canals in mandibular second molars, and the bottom row shows the cross-sectional morphology of the C-shaped canals in mandibular premolars. A thorough understanding of this anatomical variation is a prerequisite for its proper diagnosis and successful treatment. Today's presentation includes 5 parts. Firstly, the brief history of the study of C-shaped canals. Second, the morphology and the prevalence, the identification and the management of the C-shaped canals in mandibular premolars. Historically, Dr. Keys and Dr. Knowles were the first authors to describe a C-shaped anatomy in 1911. In their seminal work, this specific morphology can be observed in transverse sections of a mandibular second molar from a Neanderthal individual. And the authors noted that on the labial aspect of the lute, it shows no trace of division, but on the lingual, the lutes begin to separate into mesial and distal fangs. This morphology is indicative of a C-shaped lute. However, these authors did not assign any specific terminology to the morphological anomalies they observed. The C-shaped lute was first analyzed in detail by Dr. Nakayama in 1941, and he named it garter-shaped lute. The prevalence of C-shaped lutes in extracted mandibular second molars is about 30%. In addition, Dr. Nakayama and Dr. Toder reported in 1941 on the garter-shaped canal, focusing on its morphology and aspects of treatment. They suggested that it would be necessary to carefully prepare this type of lute canal so as to avoid lute perforation. Since then, Japanese researchers have used the term garter-shaped mainly to describe the shape of the lute, while the term C-shaped has been used to describe the shape of the lute canal. Shortly after pioneering research performed in Japan during the early 1940s, Dr. Trademan stated that the C-shaped lute morphology can be frequently observed in mandibular second molars from the Asian individuals, from the Asian populations, and the author termed this morphology the horseshoe reduction form. In 1979, Dr. Cook and Cox reported on a number of cases encountered in the clinical practice. In these cases, the teeth all had a normal configuration of the path flow with separate canal orifices. But from the post-treatment X-ray, extrusion of feeding material into the furcation area was noted. It looks like there's a perforation in the path floor. So the authors extracted the tooth. Then they found it. There was no furcation, but it is a C-shaped lute. The photograph of the lute apex showed it is a C-shaped canal, partially filled by the curvature. The etiology of C-shaped lutes and canals. The failure of the fusion of the Hedwig's epicenter shift is the most lucid explanation for the formation of the C-shaped canal. If the failure is on the buccal side, then it will result in the formation of a lingual groove. And a failure on the lingual side will result in the buccal groove. Generally, C-shaped canal is most frequently found in mandibular second molars and mandibular premolars, especially in mandibular first premolars. However, C-shaped canals can also be found in other teeth, such as the maxillary first molars and the maxillary second molars with the fused roots, and also in the mandibular first molars and the mandibular third molars, and even in the maxillary lateral incisor. Numerous studies proved the racial predilection of C-shaped anatomy in mandibular second molars. And this table shows the prevalence of C-shaped root and C-shaped canals in the mandibular second molars from the East Asia. This table shows the Chinese, the Korean, and the Japanese population. They all had a relatively high incidence of the C-shaped root and the high incidence of C-shaped canal. It ranges from 19% to 49%. And on this slide, there are two tables shows the prevalence of C-shaped anatomy in mandibular second molars in West Asia and in South and Southeast Asia. And the prevalence of C-shaped root and its prevalence of the C-shaped canal is also high, but relatively lower than that in the East Asia. It's about 7% to 10% to 19%. And this table shows the prevalence of C-shaped anatomy of the people in no Asian regions. Generally, the prevalence of C-shaped root and C-shaped root canals of the Caucasians, including Greeks, Portuguese, Americans, and Brazilians, were relatively low, ranging from 3% to 5%. And on this slide, it shows the prevalence of C-shaped root and C-shaped canals in mandibular premolars. From the top table, we can see the prevalence of C-shaped root canals in the mandibular first premolars. It is relatively high. The prevalence is about 18% to 24%. But the prevalence of C-shaped root canals in mandibular second premolars is relatively low. In 2012, Dr. Yu reported that the prevalence of C-shaped canal in mandibular second premolars is 0.6%. So, what kind of root may have C-shaped canal? C-shaped canals are typically found in teeth with fused roots, presenting with longitudinal grooves on the root surface. This kind of root is named C-shaped roots. And the groove of a C-shaped root can be located either on the buccal or the lingual aspect of the lute, or on both sides. From this table, we can see most of the grooves located in the mesiolingual surface of the lute, and about 10%, 11% located in the distal lingual surface of the lute. And also we can find about 7% of the lute presents double grooves. That is, two different grooves on different surface of a single lute. A study conducted by Dr. Fan in 2012 on the morphology of C-shaped canals of mandibular first premolars from a Chinese population showed that the prevalence of C-shaped canals in non-C-shaped lutes was 0. That is, the mandibular first premolars with no groove. If one lute has no groove, then it means it is not a C-shaped lute. And Dr. Fan found that the prevalence of C-shaped canals in the non-C-shaped lute is 0. And the prevalence of C-shaped canals in C-shaped lute means 66.4%. And in 2 years later, another researcher found a very similar prevalence of C-shaped canals in the C-shaped lutes, that is 67.5%. The mean length and the depth of the radicular grooves in mandibular first molars. The mean length of the radicular grooves of the C-shaped lutes in mandibular first premolars was reported 8.77 mm, and the mean depth was reported by Dr. Fan in 2008, and the depth is 1.44 mm. So, where does the C-shaped canal locate in the lute? Let's watch this three-dimensional animation of the lute canal morphology in mandibular first premolar. And we can see significant variations of the lute canal configuration at different levels. At different levels of the lute. And also we can find teeth with C-shaped lutes does not always have C-shaped openings. Those with C-shaped orifice does not always has continuous C-shaped canals. From this three-dimensional reconstruction image, we can see that the C-shaped canal mainly locates in the middle third of the C-shaped lute of the mandibular premolars. And the floor of the bulb chamber is often deeply seated, assuming that an unusual anatomical appearance. From both of these pictures, we can see the C-shaped canal is in the middle third. And this slide shows the three-dimensional morphology of the C-shaped canals in the mandibular first premolar. Dr. Fan classified the three-dimensional morphology of the C-shaped canal in mandibular first premolars into four types. A is a type 1. There's a continuous C-shaped canal only. In the type 2, this is a semilunar buccal canal only, with a lingual separated canal. And C is a type 3. That is a combination of the continuous C-shaped and the semilunar buccal C-shaped canal. And D means the type 4. That is a C-shaped canal interrupted by the non-C-shaped canal parts. The red one is a continuous C-shaped canal, and the yellow part is a semilunar buccal C-shaped canal, and the green part means the single separated canals. And this slide is similar to the last slide, shows the three-dimensional morphology of the C-shaped canals and with tooth structures. And this slide shows a complicated canal systems in mandibular first premolars. The green part indicates non-C-shaped canals, and the red part indicates continuous C-shaped canals. The yellow part means the semilunar buccal canals. And on the right side, we can see the cross sections at different levels of the lute. From this image, from this picture, we can see the cross-sectional morphology of the C-shaped lute varies. And this is animation of the C-shaped canal and the C-shaped lute in mandibular premolar. We can find in the middle third of the tooth of the lute, it is C-shaped. And now the cross-sectional morphology. A single canal, a single round or oval canal, and now it varies, it's changing. Oval canals, and you find it's like a C-shape. Changing C-shape, continuous C-shaped canals, and semilunar C-shaped canals. And the next part is the identification of the C-shaped canal systems in mandibular premolars. The C-shaped canals should be carefully diagnosed before the treatment starts. And the radiographs taken from several horizontal angulations, spiral CT or combing CT images will provide beneficial for the diagnosis. After the access cavity preparation, a C-shaped canal orifice could also be easily diagnosed under a microscope. This slide shows a mandibular first premolar, and from different angulation, you can see different morphology. From the left one, you may think is a single lute. It's a very simple single lute premolar. But from the middle, you can see actually it is a C-shaped lute with a distal single lute. And from the X-ray, from the radiograph, you can see the radiographic appearance is very different. The radiographic hints that help the diagnosis of C-shaped loops. In 1993, Dr. Seaman proposed that from the X-ray, from the preoperative X-ray, if there's a sudden change in the radiographic density and the taper of the canal spaces, it may indicate that a C-shaped canal. Also, if the lute appears conical and as if representing one lute with one furcation, and usually the pulp chamber appears longer than that of the contralateral premolars. But sometimes, from the panoramic radiograph or from the CBCT, you will find the bilateral C-shaped lute or bilateral C-shaped canals in the mandibular premolars. And from this side, we can see three cross-sectional images of the C-shaped lute in mandibular premolars. A means the cross-sectional shows a single over canal in the pronar set, and image B and C, there are two separate canals in the middle and the apical thirds. And image D is a mesial-distal radiograph of the same premolar, showing a type 3 canal configuration. And also, you can, from the radiograph, you can see a sudden change of the radiographic density and the canal spaces. And also, when you are doing the root canal therapy, and you take you put an anatomic instrument, a K-file, into the root canals, and take an X-ray, the radiograph may appear there's a perforation in the furcation. This picture shows the first premolar and the second premolar. It seems like there's a perforation in the furcation area. This is another case. Shows the C-shaped canals in the mandibular left first premolar and second premolars. From the X-ray, we can see there's a mandibular cyst. And from the CBCT, we can see this is a gonadal plane of the CBCT. We can see on the right side, the tooth 44 is also seems like a C-shaped lute. And from the transverse plane of the CBCT, tooth 34, tooth 35, and tooth 44 are all C-shaped lutes with C-shaped canals. And this is another case of the appearance of the bilateral C-shaped lutes. From the preoperative radiograph, we can see the tooth 44 and the tooth 45 and tooth 3-4 and tooth 3-5 are all C-shaped roots. We can see the radial density has a sudden change. And also from the panoramic radiograph, the root morphology of these four teeth is abnormal. Then the authors take a spiral CT. In the cross-sectional image of the spiral CT, we can see these four mandibular premolars are C-shaped roots, shows C-shaped roots and C-shaped canals. And then the authors do the three-dimensional reconstruction. We can find all these four roots are C-shaped roots with a very deep longitudinal grooves on the root surfaces. Then the next part is a management of the C-shaped canal system in mandibular premolars. There's a question I usually ask my colleagues and my students. Which tools possess the greatest anatomical challenges of all teeth to achieve successful treatment? Maybe you will say the maxillary second molar, maxillary third molar, or the mandibular second molar because of the existence of the C-shaped canal. Or you can say the mandibular third molar because the third molar is very deep in the mouth and the root canal procedures is very difficult. But actually, in 1979, Dr. Slowey proposed that the mandibular premolars possess the greatest anatomical challenges of all teeth because usually these teeth have the deep orifice and C-shaped canal systems and also an apical data. It is truly difficult to negotiate, to shape, and to irrigate. The first part is the challenges in the access cavity preparation. As we know from this slide, from the left side, we can see the mandibular premolars. The crown is tilted lingually relative to the root. So the crown and the root is not straight, it's tilted. So when we do the access cavity preparation, the entry point should be in the middle of the central groove, but the burr should be adjusted to the buccal side to compensate for this tilt. And the access cavity shape should be an oval slot. And another very important thing for the root canal survey in the mandibular premolars, especially for the C-shaped mandibular premolars, when we prepare the access cavity, usually you will find 2 or 3 canal orifices under the dental operating microscope, and the C-shaped orifice is less common. The situation is quite different from that of the mandibular second molars. And the challenges in cleaning and shaping the C-shaped canals. Thorough debridement of the C-shaped canal can be exhausting due to the multiple connecting fins and isthmus. And since the canal bifurcation may be observed at any level between the orifice and the apical terminus, careful exploration with a small precurved anatomic file using the operating microscope is helpful. And it has been demonstrated that the C-shaped canals is associated with a higher risk of instrumental fracture and unprepared canal areas, as well as perforation. Mechanical enlargement of the canals can lead to perforation, stripping, or both exist. Here is a very good file for the glide path management I usually use in my anatomic clinic. This is a T file. T file. It is a single file and a single-use glide path file. It is made of the austenite nickel titanium alloy and with a variable progressive taper, but it's only a single file. You can make a very good glide path before the root canal shaping. And this slide shows the U plus file system. And these systems includes the shaping files and the finishing files. Shaping includes the SX, shaping 1, shaping 2, and the finishing files including the F1, F2, F3, F4, and F5. And these tools is manufactured by the Superline company. It is made by the Maxtec 3.0 nickel titanium alloy, and the cross-sectional design is convex triangle. And the sequence of the use of this U plus file. Firstly, we need to use the crown down technique. Actually, crown down technique should be used for most of the instrument system when preparing a root canal system. And also, viscous chelator such as the glide or EDTA should be used, and also irrigate between the instruments. The sequence of the root canal shaping includes: first, we need to scout the canal with K file number 10, then number 15. And also for the glide path management, we can choose the T file. After the explore of the root canal with a K file number 10, we use a T file. Then we go to the shaping file SX, and then the shaping X1 and the shaping X2. And then we scout the coronal and the middle third of the root canals with a K file, and the shaping with the shaping S1 and S2 for the coronal and the middle thirds. And finally, scout the root canal with a K file number 10, and then you go to the F1, F2. For the contemporary root canal instrumentation procedures, actually are not capable of contacting more than 35% of the root canal walls. So the anatomical irregularities of the root canal systems, such as the isthmus, the canal fins, the cul-de-sacs, and the apical data, are not accessible to the instruments, which will leave much biofilm-covered surfaces and infected dentinal tubules in these regions. Therefore, root canal irrigation is required, is quite necessary for reducing the biofilms in the root canal systems, especially in the C-shaped canal system. And also, for the root canal irrigation, we need to do the activation with the ultrasonic, sonic, and the laser, and also the apical negative pressure irrigation. And the next part is the challenges in obturating the C-shaped canals. For the obturation of the C-shaped canals, the thermal plasticized gutta-percha obturation technique is preferred over the cold lateral condensation, because when the gutta-percha is softer, it can be packed into the isthmus area of the C-shaped canal system, and also the sealer will be packed into the isthmus area, and the root canal irregularities, and they will adapt more effectively to the apparent canal walls. And finally, I'll show one case done by myself. This case concerned a 13-year-old male patient who was referred to my clinic for the anatomic treatment of tooth 3-4 and tooth 3-5. Actually, root canal treatment of 3-1, 3-2, 3-3, and 3-6 have been done before the referral, and also the curettage of the left mandibular cyst had been completed before the referral. From this CBCT, from this coronal plane of the CBCT, we can see tooth 3-1, 3-2, 3-3, and tooth 3-6 all obturated, but tooth 3-4 and tooth 6 and tooth 3-5 are not treated, and in the bone there's a very big radiolucency. And from this picture, this is a pre-operative radiograph. Even before the root canal treatment of 3-6 and 3-1, 3-2, 3-3, this is the initial radiograph before any treatment done to the mandibular teeth. And this radiograph shows there's a sudden change in the radiographic density and the tape of the canal spaces of tooth 3-4 and 3-5. This indicates that there may be a C-shaped root and a C-shaped canals. From the coronal plane of the CBCT, the radiographic appearance of the tooth 4-4 is similar to that of the tooth 3-4 and 3-5. And we can see all these three teeth are C-shaped. That is C-shaped mandibular premolars. And after we insert one K file into the root canal system, we can find and take an X-ray. You can find it seems like there's a perforation in the furcation area. Actually, there's no perforation and there's no furcation. They are both C-shaped loops and C-shaped canals. And this slide shows the initial file radiograph of the first and the second premolars. You can see in the 2, 3, 4, the mandibular first premolar, I have put 2 files into the root canal system. That is 2 pathways. But for the 2, 3, 4, 2, 3, 5, the second premolar, I have inserted 3 files. That is, there are 3 pathways. And this is the animation for the root canal preparation and obturation under the dental operating microscope. Actually, we cannot find an C-shaped orifice in these C-shaped mandibular premolars under the microscope. What we can see is 2 orifices in the mandibular first premolar and 3 orifices, 3 canals in the mandibular second premolar. And this slide shows the post-operation radiograph of 3-5 and the obturation process of the 2-3-4. We can see 2 canals, 2 pathways. For the process of the obturation of 2-3-4, you can see firstly I put 1 gut aperture cone into the into 1 canal, and then I put another gut aperture cone into the main canal. And this slider shows the direct restoration with the composite resin, because there's no decays, there's no cracks in the tooth crown. There are only excess cavity preparation, only excess cavity. So direct restoration was done. This slide shows the restoration progress and the polishing and the post-treatment, post-restoration images. And this slide shows the follow-ups. From the bottom row, the left one is a pre-treatment radiograph. Pre-treatment, before any root canal treatment was done to the mandibular premolars and the mandibular molars. And for the second image, in the top row, shows the immediately post-treatment radiographs. And this is the 5 months follow-up and 18 months follow-up. And the last one is 6-year follow-up. And this guy came to my clinic in about 3 months ago. And from the image, from the X-ray, you can see the bone hearing is very good. And here I need to I want to show my appreciation to my supervisor, Professor Bim Fan and Dr. Franklin Tay. And that's all for my today's presentation. Thank you very much.